Bodhi is a 9-year-old Labrador cross who collapses suddenly in his backyard. When he arrives at your clinic, he's weak and hypotensive. His gums are pale, his capillary refill time is prolonged, and his abdomen feels mildly distended. You grab your ultrasound, perform an AIVR scan, and immediately spot free abdominal fluid. A quick tap confirms it: hemoabdomen. Your top differential is a bleeding splenic mass, likely a hemangiosarcoma. You start fluid resuscitation and hook up the ECG to monitor him. You immediately see why bizarre QRS complexes. You look for P waves, and you see them, but they aren't consistently lined up with the QRS complexes. Sometimes they're in front, sometimes they're buried, and sometimes they vanish entirely. You might immediately think, why complexes? No constant P waves? This is ventricular tachycardia. I need lidocaine. But wait, look at the heart rate. It's only around 70 beats per minute. This isn't a lethal ventricular tachycardia. This is an accelerated idioventricular rhythm. And pushing antiarrhythmics right now might actually do more harm than good. Hi everybody, I'm Dr. Haley, a board-certified veterinary cardiologist. I teach ECG interpretation by walking through the physiologic and electrical vector mechanics behind every ECG tracing, so you can solve rhythms logically even when they don't look textbook. By the end of this video, you'll be able to methodically differentiate an accelerated idioventricular rhythm from a dangerous ventricular tachycardia, understand exactly how systemic disease triggers it, and definitively identify the ultimate proof of this rhythm: fusion and capture beats. First, let's ground ourselves in normal physiology. In the healthy heart, the sinoatrial node is the undisputed boss. It fires at a rate of roughly 60 to 140 beats per minute in the resting dog. Why is it the boss? Because pacemaking is essentially a race. The SA node has the highest spontaneous discharge rate, meaning it is the tissue that succeeds in reaching the action potential threshold first. The other lower pacemakers in the AV node and the Purkinje fibers are latent or subsidiary. They are constantly trying to generate their own impulse, but their diastolic depolarization is simply too slow. Before they can reach the threshold on their own, the propagated electrical impulse from the fast-firing SA node crashes into them and forces them to depolarize. This essentially keeps the ventricular pacemakers asleep. However, if the SA node were to completely fail, then those ventricular Purkinje fibers would wake up to save the dog's life, but their intrinsic rescue rate is slow, only about 20 to 40 beats per minute. We call that a ventricular escape rhythm. But Bodhi's SA node hasn't failed, so why is the ventricle firing on its own? Bodhi has a bleeding splenic mass. This creates profound systemic stress, hypovolemia, tissue hypoxia, ischemia, and a massive dump of circling catecholamines into his bloodstream. This toxic ischemic soup severely irritates the ventricular Purkinje fibers, altering their ion channels and resting membrane potential, and instead of waiting quietly, the automaticity of these ventricular cells becomes enhanced. Their depolarization rate speeds up abnormally, rising from their usual sluggish 30 beats per minute. Suddenly, the ventricle is firing at a similar speed as the SA node. The boss has a challenger. Let's break down Bodhi's ECG methodically. First, we'll look at the QRS duration. We can see that it's wide, greater than the normal 70 milliseconds in the dog. And the morphology is abnormal. Look at this wide and bizarre complex compared to this sinus complex. These beats are arising from the ventricles. Second, we calculate the rate. The rate of these ventricular beats end up around 70 beats per minute. This is a critical step. A true ventricular tachycardia in a dog is almost always faster than 160 beats per minute, and it's often over 200 beats per minute. Because this heart rate is between 60 and 160 beats per minute, it falls into the accelerated category. Third, let's look at the P waves. We can see them marching through at their own regular rate. but there's no relationship to the ventricles. They are completely divorced. This is AV dissociation. But notice how the atrial rate, the P wave, and the ventricular rate, the QRS, are almost completely identical. P, QRS, P, QRS. This rhythm is driven by pacemaker competition due to enhanced automaticity, not a reentrant scar circuit like we see in true ventricular tachycardia. Because it's a competition, it turns on and then off, and is highly influenced by the dog's autonomic tone. If Bodhi takes a deep breath and his vagal tone increases, his SA node slows down slightly, the irritated ventricle seizes control and drives the heart. But if Bodhi gets stressed or shocky and his sympathetic tone increases, his SA node speeds up, and the sinus node overtakes the ventricular rhythm, with normal sinus rhythm resuming. This is why you'll see AIVR slide in and out of the baseline ECG. The sinus node and the ectopic ventricular rhythm are battling for control. This precise competition creates the hallmark vector patterns of this rhythm, fusion and capture beats. We're going to move over to this ECG trace to demonstrate these concepts. But first, let's go back to the heart model and show you what's happening. When a ventricular focus fires on its own, the electrical wave cannot use the normal fast His-Purkinje highway system. The wave of depolarization must spread slowly through cell-to-cell depolarization across the myocardium. This slow, labored spread is what creates our wide and bizarre QRS complexes. But what happens when the SA node and the ventricular focus fire at almost the exact same millisecond? The sinus impulse travels down the normal AV node pathway and begins depolarizing the ventricles from the top. Simultaneously, the ventricular ectopic focus begins depolarizing from the bottom. These two electrical waveforms physically collide in the middle of the ventricular muscle. And on the ECG, this creates a fusion beat. It looks like a hybrid, narrower than the pure ventricular beat, but wider than a normal sinus beat. It is a literal merging of the two electrical vectors. We're going to come over to this trace and I'm going to show you what this looks like. Here we've got our AIVR, our ventricular focus, and here we have a beat with a hybrid morphology, somewhere intermediate between the ventricular ectopic beat and the sinus beat. This is a fusion beat. And finally, if the timing is absolutely perfect, a sinus P wave might arrive at the AV node just when the ventricle is completely repolarized and vulnerable. The sinus impulse shoots down the normal fast conduction system and completely depolarizes the ventricles before the ectopic focus can fire. This creates a narrow, normal QRS complex in the middle of a run of wide beats. We call this a capture beat. Seeing fusion and capture beats is your definitive proof that you are dealing with a ventricular rhythm, where there's pacemaker competition and enhanced automaticity from a ventricular focus. But clinically, what does this actually mean for Bodhi? AIVR is generally a hemodynamically stable rhythm. The heart rate's adequate to maintain cardiac output, and in this case, Bodhi's collapse is from his bleeding spleen, not from his arrhythmia. Accelerated idioventricular rhythm is a bystander. In this case, it's a marker of severe systemic stress, commonly seen with things like splenic disease, GDV, pancreatitis, or trauma. Therefore, we typically don't treat this rhythm with antiarrhythmics. If you were to push intravenous lidocaine right now, you might successfully suppress the irritable ventricular focus. But if Bodhi's sinoatrial node is struggling due to hypoxia or shock, you just knocked out his backup generator and he could go into asystole. Instead, we treat the underlying cause. We give IV fluids, we provide oxygen, and we take him to surgery to remove the bleeding spleen. Once systemic ischemia resolves, the Purkinje fibers will calm down and the AIVR will usually spontaneously disappear. So, key take-home points. First, AIVR is a ventricular rhythm driven by enhanced automaticity with a heart rate typically between 60 and 160 beats per minute in the dog, which is slower than a true ventricular tachycardia. Second, because it competes with the sinus node, look for AV dissociation. Third, the absolute hallmarks of this competition are fusion beats, a collision of the two wavefronts, sinus and ventricular, and capture beats, a perfectly timed sinus beat hijacking the ventricles. Fourth, it's a marker of systemic stress, in this case, a bleeding splenic mass, and therefore rarely requires antiarrhythmic therapy. In this case, treat the patient, not the ECG. So that concludes our case study today. If you found yourself almost reaching for lidocaine at the start of this case, and now you wouldn't, that's the difference mechanism makes. And that's how we teach inside Opti ECG, starting with physiology, building through vectors, and ending with real clinical decisions. If you'd like to go deeper with cases taught this way, you'll find the link in the description below. For now, I hope you've enjoyed our case study for the day, and I look forward to seeing you in the next one. Ciao.